welcome to all of you, and thanks for joining this launch of the Civil Society Monitoring Report for 2021. We are a little bit later this year than last year. We were just checking. I think last year we launched the report somewhere in March, so now it's a good month later. Nevertheless, I think we've done a great job in developing it and in collecting all the information. So when we started developing this monitoring report, I think it was 4 years ago, we thought it is important. The original idea was to complement the existing data and information which is out there. We wanted to give a voice to civil society and share their knowledge and information, and provide also data and information from their very specific perspective. And probably the most important reason for having the monitoring report was to actively involve our members and harm reduction organizations in general in collecting data and providing evidence, and also to give them, through the report and the data and the findings, tools and a report into hands which they can use for advocacy. And it's not only for them or for our members to use for advocacy, but we see that also we can use it on European advocacy level to show what is going on and where we see gaps for implementation. As you know, everyone who knows who's doing any kind of research or data collection knows there are always challenges. I think our biggest challenge in the first start was to find willing and capable and focal points, contact points who would collect the information. That's not easy, given the fact that we do not have any incentives for our focal points. They're doing that totally voluntarily. They need to collect information and data on different topics, which means also they might be experts in certain areas. That doesn't mean that they are expert in the area, in all areas which we're addressing. This requires that they reach out to other experts in the field in their country. So I think now we did manage to find super focal points. I will tell that in a minute. Another challenge we have seen in the last years, and Rafaela and the other speakers will go more into details in that, is that it is not so easy to represent the countries by having one focal point. That means that some focal points are based in a certain city and that the information which they are collecting is not representative for the whole country. This is why at one point we also shifted to collecting more local data. But it also means that not all organizations are involved at the same level and have the same information. So meaning, if we would probably ask different people, there might come different responses. Nevertheless, looking after 3 years of this is the third and last monitoring report from our operating grant, which was finalized at the end of last year, I think we managed to overcome quite some of these challenges. We adapted a lot and complemented the monitoring. And I think this is an ongoing process. We have 36 different focal points, and they are working closely together with other experts in their country, all of them doing that voluntarily, all of them doing great work. And I see we also have a wonderful scientific advisory board, including people from the EMCDDA, the ECDC, and different experts covering our priorities, which is really helpful. And actually makes, I believe, that we have been able to do that in only a few years from the scratch, develop a monitoring tool, which really brings added value. So I will stop talking now. I hope I will give the floor to the different speakers. The next speaker will be Rafaela Rigoni. She's the scientific officer and coordinator of all research activities within correlation. And after that, we will have Daan van der Gouwe and Tuukka Tammi. Both of them are research experts and consultants very strongly involved within the monitoring. And after that, we will have a panel discussion. And I leave it now to Rafaela to do the further introduction, and we'll come back at the very end for some closing remarks. Thanks a lot.
Thank you very much, Katrin. I would like to, so as Katrin mentioned, my name is Rafaela. I am a scientific officer at Correlation, and I've been co-leading the monitoring for the past 2-3 years. And it's my pleasure to be here with you today to introduce you to the monitoring 2021. So the report that we are presenting today is the result of a learning process, as Katrin was saying, that started back in 2018. And back then, the objective that we had with planning this monitoring, as Katrin also mentioned, is to improve, to complement knowledge information in some specific harm reduction areas based on the perspective of civil society organizations. So the data we collected for this report of 2021 was collected last year between May and July. And so what we see now in the report is data reflecting on the year previous to that. So let's say between mid-2020 and mid-July 2021. And the data focus on policy implementation, as Katrin mentioned, also more on the ground level, on the municipal level. That's where our focal points work. So besides this monitoring report that we are launching today, this report then contains all the details, all the graphs, all the quotes that our focal points sent us. We also publish an executive summary, which we then translate into 7 different European languages. And both this summary and the translation, they are intended to contribute to local dissemination and advocacy in the cities and the regions where our focal points work. So as you can imagine by now, our monitoring is a huge collective effort. So we had for the 2021 report more than 100 organizations and individuals from 34 different European countries contributing to the civil society led monitoring report. And in this map, you can see the cities where our focal points come from. Most of our focal points, they are actually providing services, directly providing harm reduction services for people on the ground. Some of them also run advocacy and policy activities, some do training and capacity building, and to a lesser extent, some do also research. And most of them have contributed along the 3 years of existence of the monitoring report, and they constantly give input on the themes we should focus on, the methods which you use in the monitoring. So without the focal points, the monitoring wouldn't really be possible. So our thanks again to all of them. But many more people also and organizations contribute for this report to be made. So I just wanted to give you a brief introduction on the framework that we use. So we have, on the basis, we have the correlation, the monitoring team that supports and coordinates all the process. And then we have the expert groups, and we have 4 expert groups. The scientific expert group oversees the process, especially in relation to the methodology. And then we have 3 other expert groups for new drug trends, hepatitis C, and overdose prevention. And they co-produce and revise the survey that we send to focal points every year, each one on its own area of expertise. And they also revise the chapters in their specific areas. And the focal points, they contribute, as we said, to the planning and the revision of the whole process, and they are key actors in collecting the data. They do that in 36 cities. As Katrin mentioned, we to be more reliable with data and to talk more about really the implementation and what happens on the ground, we moved from talking about countries to talking about cities and the local level. This focal points are in 34 different countries in Europe. And they also count with people, collaborators that can be experts in the area, in some specific areas that we are monitoring, can be service users and clients, other services, other civil society organizations working in the area. So this is in a nutshell our framework. And what are the themes then that we are working on 2021? So we reported on 6 different themes in 2021. The first one was essential harm reduction services. And then we look into what type of services are available in the Cities at Focal Points Act, how this compares to the national situation, what are the subgroups of people who use drugs that are being assisted or are lacking services, what needs to be improved. We looked also into civil society involvement in drug policy. And then we are talking about the cooperation between civil society actors working with harm reduction and governments, both at the municipal level and the national level. We looked into hepatitis C and more specifically availability and access to hepatitis C testing and treatment for people who inject drugs. Where can people actually be assisted? Are the guidelines being implemented in practice? Then we also checked how overdose prevention is happening on the ground. So what are the challenges to implement the existing policies? What's happening in terms of opioid agonist therapy, naloxone, but also campaigns for overdose prevention in different substances. New drug trends is also a theme we have been looking at for the past 3 years. And then we looked into the emergence of new substances and known substance used by new groups that are still missing services, new combinations. And in the past 2 years, unfortunately, we had to look also into COVID-19 and how it affected harm reduction services and service users. So in 2021, we looked into, again, the challenges faced by harm reduction services, staff and service users due to COVID, and also the impact of COVID on overdose prevention and hepatitis C care. And interesting also, we looked into the positive changes that we saw that occurred because of the pandemic in terms of, for instance, low threshold overdose opioid agonist treatment. And we looked in 2021 whether these changes were maintained or not. So this is an overview of the themes we have been working, but enough from my side. This was to give you just an overview, and let's dive now into more interesting parts with some highlights of the monitoring results. And for that, I would like to invite Tuukka Tammi to present, and then after Daan van der Gouwe. So Tuukka Tammi is a researcher and program director at the Finnish Institute for Health and Welfare, the THL. And he coordinates the scientific expert group at the monitoring of the civil society-led monitoring of correlation. Tuukka has been involved in the monitoring from the very beginning. And Daan will come right after Tuukka, is a drug researcher at Trimbos Instituut, and he is responsible for the new drug trends part of the monitoring and coordinates the expert group on new drug trends. Just before I give you the floor for the participants, if you have any questions, please feel free to put them in the Q&A, and we can take up your questions in the panel discussion later on, or maybe the presenters can answer your questions right in the chat. Thanks, and Tuukka, the floor is yours.
Thank you, Rafaela. And thanks, Katrin, and good afternoon to everybody from Helsinki. Good to see so many people taking part. Are you sharing my slides, or should I do it myself? What was the final decision?
We are seeing your slides, yes.
Okay, so as Rafaela told, just going to present a couple of highlights or pickings from the 2 of the chapters of the report. as it was already told, that it's a very rich and thick report. We can't really deal with all of it now, but me and Daan will raise some issues from there. And in the division of work we have between the monitoring team is that I've been mostly responsible for the hepatitis C chapter, and as well as the essential harm reduction services chapter. I start from the essential harm reduction services, which is now in the report, in the monitoring survey for the next second time. In the first year, we did only cover hepatitis overdoses, new drug trends, as well as civil society involvement in drug policy, but then we decided to have a shortish question pattern and related chapter also on other harm reduction services that are there. So in this section, we basically ask the focal points to estimate to what extent do their cities have services for different populations, or if certain services are sufficient or insufficient in their opinion. And we can conclude that in a general picture, there are insufficient amount of harm reduction services in almost all European cities if we look the whole range of services that can be regarded essential. And another notion is that in most of the cities, the existing services are largely focused on or even limited to people who inject drugs and other groups using drugs in with different methods than injecting do not have that much services. Especially kind of the classical examples of harm reduction, needle and syringe exchange, and opiate substitution treatment, or OAT as it's nowadays called. The respondents also said in most cities that harm reduction services do lack funding and political support, more or less. And in many cities, the integration of harm reduction services to other parts of health and social care system is quite weak. What needs to be developed in the next rounds of monitoring of civil society harm reduction services is to pay more attention to the quality of services. Now we have rough estimations on the amount of available services and access to them. Can I have the next slide, please? And as one picking from the data, we can see that there are, in general speaking, European-wide speaking, there are some geographical divides in harm reduction service coverage. First of all, there's a divide between Eastern and Western Europe. Generally speaking, again, harm reduction services are better available and accessible in Western Europe and less in Eastern Europe, although there are also some positive exceptions in the Eastern side and opposite exceptions in the Western Europe. We can also see from the responses that there's another geographical divide inside the countries. There's a quite a big difference between capitals or other big cities compared to small towns or rural areas when it comes to harm reduction service availability and coverage. So in smaller places, people who use drugs can be isolated and lack harm reduction services. Next one, please. And then something about hepatitis C related work. Testing and treatment are the main areas of interest in the questionnaire. We know that WHO has a global goal in 2030 to eliminate viral hepatitis from the world. And we know that in Europe and probably also elsewhere, people who inject drugs account for the majority of new cases of hepatitis C infection. But we know also from the WHO reporting that only maybe a quarter of people infected from hepatitis are aware of the infection, and only some 8% of those who are diagnosed have so far been treated. So this is quite far from the global goal. And like also 2 years before, our results from the monitoring data show that despite some progress in many cities and countries, hepatitis testing and treatment for people who inject drugs remains still insufficient, and further improvements of the existing continuum of care interventions are definitely needed. As you can see from the right side of the slide, these are just examples from a couple of countries, but in the report you can read lots of kind of free text reporting of the problems that occur in the access to the testing and treatment and the integration to the other services. And still the last slide. Now it's the positive situation that new drugs, the DEAs, are available in all countries, but still, like in the previous years, in practice there remain different restrictions for people who use drugs to the access of these drugs and also related services. For instance, treatment still remained quite centralized and available only in some key settings, and also for testing there are still barriers. We know that it's important to try to integrate testing and treatment to the same facilities, same places with a low threshold, but this far in a general picture, of course, there are positive exceptions to this. The integration of testing and treatment in the same local location is still too rarely the case. But again, there are positive examples also, like the quote from Vienna, where they are really satisfied with the situation now with regard to hepatitis work. Thank you. I think I'll stop here and let Daan to continue on different chapters. Thanks.
Thank you very much, Tuukka. I will take over from here, and maybe Roberto can share my presentation. Yes, this is the one. Hello, everyone, friends and colleagues. Hello from Rotterdam. I will present very shortly some highlights from the new drug trends survey that was conducted last year. Next slide, please. What we aim to do within the framework of this project is to gather complementary data, data complementary to already existing monitoring systems, especially the EMCDDA. As we all know, they compile every year a huge amount of data regarding drug use within the European Union and abroad. But these data, they are a bit old already when they are published, and we thought we could do it better by adding data from grassroots level, and also to do that at a more rapid pace than others do. This was the plan. The reality is slightly different, as we understood by now that it takes quite some time to actually gather data, process data, and also publish them. But nevertheless, we believe that the way we have gathered our data and the quality of the data is such that it really adds to what's already being collected by others. because it's grassroots level, so it's coming directly from NGOs working with people who use drugs. By doing so, we are able to early inform the same group of people, the people who use drugs and others, to when extra dangerous drugs are entering the market. And as such, more rapid data should be available. Next slide, please. Thank you. Just a few highlights of the questionnaire of last year. We have only 7 questions, and I highlighted 3 of them. I have to say that we have 36 focal points. 2 of them did not fill out any question at all, and the 34 remaining did. However, as you can see here already in this slide, the majority of the focal points mentioned no changes, basically in any regarding any question. But when it comes to the emergence of a new substance on local drug markets, 11 out of the 34 they said yes, we have seen a new substance on the market, on the local drug market, and this was in half of the cases dealing with synthetic cannabinoids. Interesting here was that the use of this substance was sometimes intentional, as people want the stronger effect as compared to cannabis or marijuana, hashish and weed. But it's sometimes also unintentional, as there was we saw through drug checking services that there was a pollution of cannabis sold cannabis in coffee shops in the Netherlands, but in the streets as well as elsewhere in Europe. It was polluted, the cannabis, with synthetic cannabinoids, so it was actually an unintentional use. So this finding was not surprisingly, but it was actually adding quality to the data that we already saw from EMCDDA, for instance. Next slide, please, Roberto. A known substance newly used by focal points target groups were also, half of the focal points said, yes, we have seen that a known substance being used by a new target group that previously did not use the substance. And then you have to think about substances such as GHB, methamphetamine in some countries, NPS such as 3-MMC, alpha PVP, the cannabis edibles, cocaine in some areas, crack cocaine seems to be on the rise in some areas in European Union, interestingly. Snus, which comes from, I believe, Sweden, but also now going down its way to at least the Netherlands, and I think also Belgium. And oxycodone has been mentioned by a few focal points, which in itself is a very worrying development, of course. Next slide, please, Roberto. And the last highlight that I would like to highlight is 10 focal points they report to have initiated new services, to have initiated services for new target groups. Chemsex communities is a group that has seen throughout Europe an increase in people who engage in chemsex. Some young people in some countries. Interestingly enough, not surprisingly and sadly, veterans from the first Russia-Ukraine war. So basically, in cities in Ukraine. This was actually before the war, the second war started, because as you know, in 2014, already the Russians occupied certain territories in eastern Ukraine, and people were sent there to fight and came back addicted, or maybe not addicted, but started to use drugs to cope with the things they have experienced as being in a war, and they started using drugs, especially heroin and heroin type opiate type drugs such as methadone, and also migrants from South Asia or from Arab-speaking countries and Somalia. Next slide, please, Roberto. So a few conclusions that I'd like to make regarding the new drug trends monitoring, as we have done for 3 years already, is that we believe that by doing so, it deepens the information that's already available. So it adds quality to other data who are mostly very general and covering a nation rather than a city. So the city level was really, I think, a good thing that we chose to monitor at city level rather than at national level. But there's also a question about, as I mentioned at the start of my presentation, is that most focal points report no changes. They simply say, well, we have seen no changes. And it's a bit complicated and difficult to analyze those responses. What does it mean? Does it mean that local drug markets and changes in local drug markets do not come overnight? So maybe this 1 year monitoring is not suitable. Or perhaps there's other reason why people report no changes. For instance, that they just have, they're fed up with the questionnaire as it is, and they think, well, enough of this questionnaire, I'll just simply fill out no changes, or other reasons we don't know. So there will be an issue for this year's monitoring to cover that. And then my last slide, thank you, Roberto, is well, not the last slide, but the one before, is as already Katrin mentioned, there we have some difficulties with limitations regarding the civil society monitoring. People are not equipped well enough to do this type of work, which makes sense because they're working at grassroots level, serving the needs of the people who use drugs. Sometimes we have problems with correct interpretation of the data that we received. Reliability of some data is sometimes questionable, as it is in complete contrast to other known sources. And most importantly, that the appearance of a new substance is based on assumptions rather than on lab analysis. And this now, thank you, Roberto, will be my last slide. We recommend that it's strongly, we strongly recommend to implement drug checking services throughout the European Union at city level. As we know, that drug checking services are at the forefront when it comes to identifying new, missold or adulterated substances, as the examples in my presentation have shown. But they also allow for quick responses, such as early warning campaigns in general, aimed at preventing unintentional consumption of missold substances or of adulterated substances that may have serious adverse health consequences. So with this recommendation, I'll like to give the floor back to Roberto, I think. Thank you.
Thank you very much, Daan and Tuukka, for your great presentations and for giving us some hints of what's in the report. I would like now to open the panel discussion, and for that, I would like to invite both Tuukka and Daan to be back on their cameras, and then I would like to welcome two other colleagues. So Iciar Indave is a scientific agent from the support to practice sector, the public health unit of the EMCDDA, and she's responsible for health and social responses. So welcome, Iciar. And Jerzioska, I'm sorry if I'm mispronouncing your name, is chair of the working group on the EU drug policy of the Civil Society Forum on Drugs, and now also joining, luckily, our monitoring team starting this year. So welcome all to the panel. And to kickstart the discussion, I would like to ask you to reflect a bit on the opportunities of using civil society-led monitoring as this one and its results, and to produce advocacy. So we know luckily there is a considerable amount of knowledge being produced around harm reduction, mostly still by universities, research institutes, or other agencies, but also increasingly by civil society and people who use drugs. And we have been trying to use this evidence to have an overview on the state of harm reduction, to see the context in which people who use drugs live, but also to advocate and hold governments and donors accountable for funding, for the quality of harm reduction services, for policy reform, for policy implementation, and to improve accessibility, availability, and ultimately quality of life for people who use drugs. So if you could reflect, like coming from your different perspectives, could you reflect from your positions, how do you think we could better use a civil society-led monitoring effort in terms of advocacy for harm reduction in Europe? Do you have good practice examples you could share or ideas that you could share with us? And you can feel free, but if I may, I can give the floor to Iciar first. But feel free to contribute.
Okay, so yeah, I will start. I think it's easier. Thank you for having me. To all of you, thank you for the presentations. Thank you for the report. Congratulations. I have to say that I may not be the perfect person to talk about advocacy, but I certainly can talk a bit about the perspective that I would have as somebody who has recently joined the EMCDDA. So I'm not haven't been long in the position of responses, and I come from the field. That's, I think, something important. So I do value a lot the added value of this complementary information that we get when you do some type of monitoring in a qualitative way. I think that's very important to say that this is qualitative information that nicely complements traditionally quantitative monitoring, and also other efforts that we have here on board to complement with social sciences and other type. And as such, I think not directly talking about advocacy, but maybe referring to opportunities to help in decision-making processes for policymakers or other stakeholders, people who are key. I think it's very nice if you consider that this complementary and local monitoring, taking into account under the traditional monitoring, big picture, national focal points and European point of view, combined together nicely to inform future research, and probably something that might be a bit of a problem in some areas of harm reduction, to produce higher levels of evidence, so evidence that in fact is good enough to support certain practices. And yeah, so as such, I think it's just a perfect combination of efforts. And I think that's the main point I would say.
Thank you so much, Iciar. If I may ask Iga.
Yeah, thank you, Rafaela. Well, I would actually also deter a little bit from your original question. I think that, like, the perspective that I can think of for myself now is a perspective of a person who's been working in the fields for the last 10 years in Central Eastern Europe. And as I think Tuukka mentioned, there are huge differences in your report between the availability, accessibility of different services between Western and Eastern Europe. The problem that two kind of problems that I see in this context. So we are talking about evidence-based policies, right? But this is how kind of politicians, decision makers try to kind of influence researchers, universities, civil society organizations to produce this evidence. But once it is produced, it seems a little bit kind of undervalued, maybe. And from this Central Eastern European perspective, I see two main problems. One is kind of maybe not sufficient trust to civil society organizations and the general weakness of civil society as such compared to Western European countries. And the second issue is that harm reduction also is not very supported by the decision makers. So from my perspective, as a professional in the field, this kind of evidence that is really of a very high quality and at the same time adopts a completely different perspective from, for example, EMCDDA data. So it's very complementary and also shows how the things work, not only whether they work or not, whether a service functions or not, but also how and what are the limitations, what are the barriers in delivery. I think this is extremely important information for the decision makers. But first of all, in order to kind of be able to use this kind of evidence in the first place, we need to kind of put drug policy as a policy field high on the agenda, on the political agenda, which it is not at the moment. I know that it is not in the Western Europe either, but I think that in Central Eastern Europe even less. And also kind of build trust between the political leaders, decision makers, and the civil society. And this is extremely difficult in the current context also of the democratization of different countries and kind of deteriorating relationships. So overall, for me personally, I would say that this kind of evidence combined with what we have officially should be in itself a kind of value and should be in itself an inspiration for policy changes, for innovation and so on. It is not happening. So the challenge here is to figure out how it is possible kind of to change the context, to change the situation, to make this usable in the first place.
Thank you very much, Iga. You both have very, very important points there with the value of harm reduction and the complementarity of the civil society collected data in regards to other monitoring efforts. Daan or Tuukka, would you like to complement that or respond to some question from your perspective, having worked on those results and data?
Dan, do you want to start or shall I?
Please do so.
Just one thought that I think I am not the one who can say how should we do advocacy on the basis of this data, but I think that in our role it's most important to provide kind of rich material for inventing different strategies for advocacy, and this means in practice that we should have both, like I did also in my presentation, both kind of bad examples of bad practices and examples of good practices, not only bad or good, but they both can be used in advocacy to when people compare what they have and others have better or they have worse and so on. So I think that the comparison and model taking from good ones, that's something that may come out from this report for advocacy.
Well, I can only reflect on my expert groups on new drug trends and thinking of added value. Although we have a lot of limitations in our work and we have seen some problems during the last 3 years, there's also a lot of opportunities and a lot of things that we do have, and we should, in terms of advocacy, I think NGOs working in this field and collecting data in a structured and systematic way really adds to their, being accepted by other parties, including maybe EMCDDA and national parties, and because I think the data that we have gathered is really relevant, as it identifies gaps in current data collection. It addresses the needs of people who use drugs much clearly and directly than others do. And we have also heard from previous monitoring reports that actually NGOs and focal points, they use it as an advocacy tool, to fight for the rights of drug users, and to fight for services and to keep services going, which is absolutely necessary, as probably Katrin mentioned already. In parts of Southeastern Europe, harm reduction is almost non-existent. So I believe that the more data we gather and the more dissemination of data that we have gathered, the better for bringing back harm reduction in Bulgaria, Romania, and other countries in that area, which is a crying shame that it's gone already.
That's definitely a super important point that we have seen, as Tuukka mentioned, this divide and how we can use the data also to try to advocate for a decrease in this divide. It's an important role that we can play as well as civil society in different networks, different organizations. And to continue, this, you all mentioned the added value, let's say, of civil society-led monitoring efforts. In regards to other efforts, I made some notes here. The qualitative nature of the work, inform future research, high levels of evidence. We also have seen that it helps, for instance, to point at bottlenecks of policy implementations. I think Iga also mentioned that. So not only whether services are working, but how are they working? So that's one thing, offering a perspective from the front lines. And by including civil society in the participation or the collection of data is also, we believe that is an opportunity for civil society to reformulate indicators and define data needs that we have, so to use that in advocacy. I would like to hear a bit of your, if you have any other perspective apart from what you said already about how you see this added value of civil society in collecting data and producing knowledge and evidence for harm reduction in Europe. Please, who wants to take the floor?
Maybe I take the floor again, so we do the same round. I don't want to repeat myself, but I want to compliment, as I said, and I think that's the major point. It is absolutely complementary. We get a sense of the local community with this data. We get a sense of the social civil society part, and we have this qualitative information that complements the national focal points information in all aspects. And I think that's what you can, in the end term, in the future, probably turn into data-driven decision-making pathways. So what you have been talking about. So really, maybe there is no perfect way yet to translate the data and drive decision based on that. But many people and in many other fields are working on that. And that's something, as an MD and medical doctor from background, I sometimes think benchmarking from other fields where this has been under evolution for a long term is also sometimes a good idea. So that's my main point. It's the same, but insisting in it.
Okay, so if we are doing the same round, then I'll overtake. So yes, I mean, many of the things that I've been thinking about have been already said, but also what I see are kind of like as a potential probably in this context is that the civil society-led monitoring can, to a large extent, be based or driven by the actual needs of people who use drugs. So if we have monitoring of services that are inspired by information that we received from the people with lived experience, this is probably the relevance of the kind of data collected can be only very, very high. And the other point that I don't think was mentioned yet is that in general, in kind of the landscape of doing research, in high level of involvement of civil society in this activity contributes to the democratization of research as such. Okay, so it becomes not this kind of maybe a little bit elitist and distant activity and results that are not understandable for the common folks. But also my impression is that civil society-led reports, research reports, are also more digestible for an average person than research results that are published in the peer-reviewed reports, which is also, I think, it also can help in kind of creating momentum, because if the society understands what we are talking about, then they may take a stand supporting or being against it. But first, they need to understand that, and I think that this is one of the very important advantages here as well.
So I think it's now my turn. Well, I think monitoring data consists of at least three kinds of information. The one is kind of complementing information, something that is not reported elsewhere, it may be the same information may be gathered by the EMCDDA, but as there's a huge amount of data that you gather to Lisbon, only part of this is publicly reported. I know that from the Finnish reality. So maybe our report, the civil society report, may report also these things that are left unreported by the official channels. And then the second kind of information is more or less repeating the same, but maybe in a different voice or different ways, telling the story from the harm reduction services approach or civil society approach. But then the third one is something that disagrees with the official reporting by the RATOX network. And there are in maybe not in all chapters, but in many chapters, there are kind of challenging views that what is in the European drug report about our countries, it's only a half truth, or it's not like that in our city, it's in the neighboring city, that's so. But telling about the regional, local differences inside one country, as we are also a RATOX focal point, our institution GHL at Helsinki, and I know that there are huge differences inside Finland when it comes to services and realities, and in many cases what is reported in the European report is saying if we have it or not in a given country, but then the reality is more diverse.
Well, I have nothing to add to what I already said, because I talked already about added value. So in order to save time, I'll just leave it with this. There's also actually a question in the chat.
There's a question for you in the chat, exactly, if you could address that.
I can address that. It's a question from Michel Voisin. I think it's French. Yes, okay, well, yes, both in the framework of the monitoring from correlation and in the framework of another project, we collect data from the drug markets in neighboring countries, more specifically from the East ENP regions, so countries such as Belarus, Moldova, Ukraine, and Georgia, Armenia, and Azerbaijan. And Ukraine, as well as Georgia, are also having a focal point to the correlation network. So we do collect those data. Let me see what the rest of the question was. Let me see, where can I find it?
It's in the answered questions now. So whether the information, especially related to newly emerging drugs, could inform the European context in terms of foresight and trends, and possibly inform needed harm reduction intervention services in Europe.
Yeah, well, what we do take into account is the needs of drug users and people who use drugs, and the changing needs when it comes to emerging drugs. For instance, MPS is an issue of concern for which there's no, in many countries, there's no harm reduction services dealing specifically with MPS, leave alone treatment. And the same is true for chemsex. There is an issue with chemsex in a growing number of countries, also in that region, while treatment or harm reduction services are lagging behind. So we try to address that, possibly also within a correlation network, but also in different European projects that we are currently enrolling. And the one I'm referring to now is called Drug Prep, in which we look at current drug trends, and also we try to make a foresight for what will be happening shortly in the next few years, and how can we as European Unions and persons in the European Union and organizations within the European Union can prepare ourselves for changing drug markets. I hope it answers a bit your question.
Thank you, Daan. And we can share maybe in the chat the link to some information on drug prep. I saw that Iciar had a hand. No, you don't want to say anything. So, and your question was answered, I see then. Well, I think we should round up because we have reached already the time for our webinar. So I would like to thank a lot all the panelists again for your contributions and the discussions. And I would like to give the floor to Katrin to say some words for some closing remarks.
Yeah. Yeah, thanks from my side as well to all the speakers and all the participants. Listening to all the discussions, I mean, we all know that research is needed, but we also know that sometimes research is done and that there is a gap between research and practice, meaning that some of the research activities are far away from the reality in which we work and where people who use drugs are living in. And I think the monitoring, with all the limitations we might face at the moment, is trying to bridge this gap. And one thing last year, at the end of the year, we were in a quite insecure situation about the funding for 2022, meaning as well that we didn't know if we could continue the monitoring activities. And we discussed that during the harm reduction conference with our focal points. And what was amazing that there was very big commitment from the focal points themselves, saying that there is a need to continue that. And in that way, I already would like to thank two Finnish organizations who offered their financial support. It's the A-Clinic Foundation and the EHRN Association in Finland, who contributed with an amount which enabled us to start up the activities in 2022. And will enable us. Now we are in the position, we have received a grant for the rest of the year, and this is very nice, but I think without this Finnish input, we wouldn't have been able to do so. So thanks to them already. I also would like to ask Roberto to show a slide, because we saw there is a interest in discussing things and the time was probably short, but there will come up some follow-up webinars on the monitoring, showing some more detailed research on the specific topics, and you will see, yes, the next one exactly. So today we had the launch of the monitoring report. And here you will see that there will be one on hepatitis C and drug use on the 15th of June. There will be one on COVID-19 in July, state and challenges of overdose prevention in September, and monitoring new drug trends in October. And I hope that you will be able to join the meetings and the webinars and contribute. We will have a bit more time to discuss things at that time. And yeah, I think for now, I would like to thank you again and close the meeting. Thanks a lot.